Urinary tract infections are really a global issue, specifically with patients who have spinal cord injury. And the main reason is because it's very difficult to understand what the exact diagnosis is. We have so many different definitions that have been throughout the literature that make it challenging. And even societies have different definitions. The first place we need is a unified definition of what is a true urinary tract infection. And I think the driver really needs to be symptoms. Before we look further into the impact of UTIs on IC users, let's see how UTIs may occur to our knowledge today.
How do urinary tract infections develop? Bacteria and fungi can be found around the urethral opening and in the urethra itself. These microorganisms are simply part of the body's normal flora, but some can also be pathogenic, most often E. coli, and originate from the colon or feces. If these bacteria enter the urethra or bladder, they might cause what is termed a lower urinary tract infection. This can happen in two ways. The bacteria move up the urethral mucosa on their own, opportunistically, or enter via a catheter. If they enter the bladder, they might begin to replicate in the lumen, or attach to, invade, and replicate in the bladder's epithelial cells. This replication will continue rapidly within the cells until their walls rupture, releasing more bacteria into the lumen. As epithelium colonization increases, it can cause inflammation or cystitis, triggering a response from the immune system. When this occurs, the patient can experience a range of symptoms and signs, including fever, bladder irritation, and the urge to urinate. A urinary tract infection can be defined by the presence of bacteria in the urine and symptoms. If there are bacteria in the urine, but no symptoms, this means that the immune system has not been triggered, so it is not considered an infection, but termed bacteriuria. Sometimes, even after treatment, residual bacteria can transform into different morphologies that are resistant to the immune system and lie in reservoirs. Occasionally, these reservoirs of bacteria can cause a new infection. If bacteria move from the bladder up through the ureter, this can cause an upper urinary tract infection, or pyelonephritis, in one or both kidneys, which left untreated can result in sepsis. So while bacterial multiplication in urine will show positive urine culture, a urinary tract infection is only diagnosed when symptoms are present.
For some patients, UTIs are a very frequent problem. However, others are really not prone to UTIs, and consequently, this is one of the challenges that we have regarding UTIs and IC users. Someone who's on intermittent catheterization actually has other risk factors for UTIs. Inherently, their bladder lining may be abnormal due to the fact of potential trauma or irritation. It can also be affected by underlying disease states. You also add to the fact of just the actual process of instrumentation can pose trauma to the urethra and urothelium. In addition, when normal people void, they have a washout. They can sort of let the urine flow out, for which catheterization users don't have that ability. Other factors that can lead to it are having the inability to empty their bladder completely. Sometimes they will remove the catheter prior to complete emptying. Consequently, urodynamic test is very important because that gives them a sense of what's a safe pressure to allow the bladder to get to. Let's look at the differences between a normal and neurogenic bladder and how that leads to increased risk of UTIs.
How does the bladder work normally? As you see here, the nervous system controls bladder function by sending signals between the brain and bladder via the spinal cord. The urinary tract is protected against infections via the body's protective mechanisms. Normal bacterial flora in the urethra competes with pathogens and prevents them from thriving. And flushing via urination prevents bacteria from reaching the bladder. If they do enter, two protective mechanisms work to halt further growth. Normal flora competes against the pathogens, and the glycosaminoglycan layer on the epithelium surface makes it difficult for bacteria to attach. They're then flushed out during urination. If some bacteria invade bladder cells, immune response mechanisms usually defeat them and prevent infection. But what happens if a neurologic disorder is present? In some cases, signals between the bladder, bowel, and nervous system are impaired, either completely or partially. The person may not be able to consciously contract the bladder and relax the sphincter, and they may also not realize their bladder is full. Or they might have an overactive bladder with many contractions that needs to be treated. So, neurologic disorders may lead to high intravesical bladder pressure and impaired bladder compliance. For a bladder that cannot contract, or for a treated overactive bladder, emptying may depend on the use of intermittent catheters. What happens to the urinary system and the protective mechanisms in people with neurologic disorders? These people can have compromised immune systems, which can lead to changes in bacterial virulence, making it easier for pathogens to thrive. Inserting catheters into the bladder from the urethral area inevitably allows bacteria to enter, but more so if the procedure is done in an unhygienic way. Poorly coated catheters, or reusable unlubricated catheters, put greater responsibility on the patient. This lack of lubrication leads to higher friction between the catheter and the mucosa, which may lead to urethral trauma and potentially bacteria entering the mucosa. And with no natural flushing, the bacteria cannot be removed. A proper urine flow is required to reduce the risk of UTIs, and this is compromised by a low fluid intake and low catheterization frequency. Additionally, the bladder should be emptied completely, as residual urine allows bacteria to remain in the bladder and infect more cells. This can occur if catheters are not repositioned at the end of catheterization. Without adequate education, users might not be aware they need to reposition, or they might not follow the recommended catheterization frequency. To sum up, the risk of UTI increases when defense mechanisms are compromised. Now, you've heard many of the risk factors. You'll find even more in this comprehensive model developed to provide you with a scientific overview of the factors relating to the potential development of UTIs.
The risk model was developed with 5 different colleagues from different disciplines, including neurology, physical medicine rehabilitation, and urology. Consequently, we took it upon ourselves to really review the literature, look at evidence-based, and ultimately, using a Delphi process, the model is constructed into 4 key categories of risk: intermittent catheterization, compliance, general conditions, and local urinary tract conditions. This model was developed for neurogenic urinary tract dysfunction groups. However, this too can be used for other patients who are on intermittent catheterization. Let's hear from some of my colleagues that worked in developing the model.
For years, clinicians and scientists are trying to solve issue how to prevent, how to treat urinary tract infections. Unfortunately, it's a multifactorial condition. Multiple issues involved when person develop urinary tract infections. And that's why it's not only one factor that we can treat or manage. It is also has to be realized that when clinician, as a physician, nurse, or occupational therapist, physical therapist, has a structured assessment tool or clinical practice guidelines to assess specific condition, it helps to unify results from different clinical practices between cities, between countries. And that's why developing of these kind of tools like UTI assessment tool will help us to be unified around the world with our understanding what's happening with urinary tract infections, how urinary tract infections happen, and then what we can do to manage them.
Urinary tract infections are an important topic in my clinical practice because they are highly prevalent among patients that rely on intermittent catheterization. The UTI risk factor model is truly important for us healthcare professionals because while we are just treating these patients, there are so many factors that may be related to persistent UTI that it's quite difficult to remember all of them. We've been working on a practical tool which may help us to bring all this insight to the clinical practice. In the end of the day, that's what we want, because in a face-to-face consultation with our patient, we want a practical tool that may assist us to convey the message to the patient and have the patient also participating in the decision process. So, while talking to the patient, you can just look at its different aspects and discuss with the patient strategies to prevent UTI. We truly believe that this is the proper way to bring the science to the clinical practice. And in the end of the day, the benefit will be for our patients.